Hello, my name is Amira Ramirez, and today I'm going to be presenting a case of a patient with Lyme disease concern and a history of lupus. Subjective data. Patient AB, 29 years old, female, white Hispanic, comes with a complaint of a red area on her left hand with some swelling and discomfort. Also, she states she feels off and just like tired and run down. Characteristics. The onset started a few hours after noticing a bug in her garbage. Location in the dorsum of the left hand. Duration for 2 days. Characteristics. Localized redness, mild in duration, discomfort, and general malaise. Aggravating factors, non-identified. Relieving factors, ibuprofen helps a little bit. Timing is constant mild discomfort. Malaise is generalized and persistent. Severity, pain rated 2 out of 10. Malaise is mild but annoying. Other subjective data. Medications, ibuprofen 200 mg PO PRN. Allergies, none. Past medical history, mild systemic lupus. Not currently on immunosuppressants. Family history, mother, hypertension, father, type 2 diabetes. Past surgical history, none. Social history, lives alone, works at a desk job, no tobacco use, no drug use, and occasional alcohol. Recent exposure to potential insect bite while taking out the trash. Review of systems. General reports feeling off with fatigue and mild general malaise. Skin, red, slightly swollen area to the left hand. No headaches, no visual changes or sore throat. No chest pain or shortness of breath. No urinary complaints. No new joint pain or swelling beyond lupus baseline. And no dizziness or focal weakness. Objective data, vitals and physical exam. Blood pressure 112/68, heart rate 74, respirations 16th, temperature 98.2, oxygen 99% in room air. Exam findings, 2.5 centimeters erythematous, warm, mildly indurated lesion on left dorsal hand. No central clearing, fluctuance or drainage. No lymphadenopathy. Lungs clear. Heart rate regular and regular rhythm. No joint swelling or systemic signs of infection. Objective data, labs and diagnostics. Labs, none available for review at time of visit. Diagnostics, no CBC or Lyme serology order. Patient is asymptomatic beyond malaise and rash. No systemic signs of infection. Decision made to treat empirically with prophylaxis based on exposure, history, and immune status. Plan, order CBC, CRP, Lyme serology if symptoms worsen. Screenings, Pap smear, normal last year. STI panel, negative 6 months ago. TSH, normal 1 year ago. COVID, fully vaccinated. Lipids, not age indicated. Assessment, diagnosis. Primary diagnosis, suspected early localized Lyme disease. Secondary diagnosis, mild lupus, stable, and general malaise. Those are confirmed. Insect bite, early cellulitis, and contact dermatitis. Those are differential diagnoses. Primary diagnosis: early localized Lyme disease, which is suspected. ICD-10 is A69.20. The rationale: there was a bug exposure, there's a skin lesion, there is mild systemic symptoms, autoimmune comorbidity. Based on CDC guidelines, patient meets prophylaxis criteria except tick identification. But shared decision-making supports treatment due to high risk. Plan: diagnostics and pharmacological treatment. Labs order, none at this time, will order if symptoms worsen or spread. It will be considered a CBC, a CRP, and Lyme serology if systemic involvement suspected. Pharmacologic treatment: doxycycline 200 mg PO once. CDC recommended for Lyme prophylaxis. Retail price without insurance is approximately $10 to $25 at most US retail pharmacies in the last year. Might be $0 to $5 with common discount programs like GoodRx or Single Care. Also continue with ibuprofen 200 mg PO PRN for discomfort and inflammation. Medication education: take with food and a full glass of water. Avoid lying down for 30 minutes after taking. Wear sunscreen and avoid prolonged sun exposure. Watch for symptoms of GI upset or allergic reaction. And it's not recommended to take this medication during pregnancy or for children under 8 years, but in this case, this wouldn't apply. Plan: non-pharmacologic and prevention follow-up. Non-pharmacologic: rest, hydration, warm compress to hand. Avoid scratching lesion. Prevention strategies: use insect repellent. Inspect skin after outdoor exposure. Report worsening, fatigue, or rash spread. Monitor for erythema, migraines, joint pain, and fever. Follow-up plan: follow up in 5 to 7 days. Return sooner if new symptoms appear or the ones that are already there worsen. Role of the nurse practitioner. We as a nurse practitioners need to perform a comprehensive assessment and a review of systems. Recognize early signs of vector-borne illness. Apply clinical guidelines and evidence-based practice. Provide patient-centered education and prevention counseling. Use shared decision-making, especially in special populations like with autoimmune conditions. Clinical guidelines and evidence-based practice. CDC supports a single-dose doxycycline if tick exposure suspected and prophylaxis criteria met. Research: patients with lupus are more susceptible to infection and may present atypically. Nurse practitioners play a vital role in early detection and patient education in primary care settings. References. Thank you so much.